All right, let's get started. Hello, everybody, and welcome to ISGyP LiVE Journal Club for October. I'm your host and moderator, Talia, joining you live from Melbourne, Australia. Our topic for this month is ovarian, serous neoplasia and benign entities, and we are lucky to have 3 pathology trainees presenting today. I'm also very pleased to say that we have Dr. Natalie Benet online with us today, and her presence certainly makes my job easier, and I appreciate her joining us. While our audience members are still joining, I'll go over some basic information regarding Journal Club and mention a couple of upcoming events. Natalie, if I could have the next slide. Thank you. As I'm sure you're all aware by now, I've started hosting every alternate month of ISGyP LiVE Journal Club with Dr. Natalie Benet, who hosts her sessions from the United States. So this means that every other month, Journal Club will occur at a time that suits those of us in the Eastern Hemisphere of the world. And our aim with this is to increase the reach of Journal Club and engage a larger global audience. Remember that if you can't be online at the time of the session and you register for Journal Club via the ISGyP educational website at isgyp.ca, you will be sent a video link to watch the recording afterwards. Recordings are also posted to YouTube. Our aim with Journal Club is to create a forum where pathology trainees and early career pathologists can present and discuss papers in a supportive environment. We will provide you with a journal article, and there is an emphasis on mentoring you in the lead up to the session. So this includes providing written feedback on your presentation and running a practice session online so that you can familiarise yourself with the digital format. Next slide, please. ISGyP has also recently launched another new initiative for trainees, and this is the Interesting Case Presentation series moderated by Dr. Jennifer Bennett, who's also with us today. This will run to a similar format as Journal Club with 3 presentations per session and mentorship offered in the lead up to the day. If you think you'd like to participate in either Journal Club or the Interesting Case Presentation meeting, please contact Dr. Benet, Dr. Bennett or myself via the email addresses listed here. You don't have to be an ISGyP member to participate, and a reminder that ISGyP membership is free to all trainees. You can find out more by visiting the ISGyP website, and all of the ISGyP educational events are also listed there and you can register for those. So on that note, next slide, I'll cover a couple of upcoming events that are worth being aware of for October. So we have an ISGyP podcast on endometrial biopsy reporting, and the speaker is the amazing Dr. Nabina Singh, and this is moderated by equally amazing Carlos Paraharan. This is airing on October 27 at 12 midday US Eastern, and you can also access this recording afterwards via the internet. And we also have the next session of the ISGyP LiVE Interesting Case Presentations, which will air on the same day, 1 hour later, 1 p.m. US Eastern Time. Next slide. So the learning objectives for Journal Club are listed here, and as you can see, the main aim, as I've mentioned, is to engage junior and trainee pathologists and to provide mentorship. And on the following slide, here is the template that we provide for you for presenting papers. And I think this is also a really good way to critically evaluate the literature and approach writing up papers yourself. So next slide is our schedule for today. We've got 3 speakers who will speak in the following order. We have first Dr. Rebekah Divakaran from Melbourne, Australia. And next is Dr. Aanchal Agarwalla from India. And finally, Nithya Roopa Prem, who's also from Manipal, India. And we'll finish, if we have time, with questions and discussion at the end. Next slide. If you'd like to ask questions as we go along, the Q&A button is down the bottom of your screen and you can click there to post a question. You can also upvote a question that you would like to emphasise by using the thumbs up sign down the bottom. Also, at the end of the presentation, a survey will pop up, and we'd appreciate if you could take the time to fill this out so that we can continue to improve this event going forward. So the next slide is this month's theme and papers. As you know, it's ovarian serous neoplasms, and we've also included one paper on benign ovary. Our speakers and their papers are, as I've said, Dr. Divakaran first, presenting mutational spectrum in clinically aggressive low-grade serous carcinoma / serous borderline tumour of the ovary, clinical significance of BRCA2 gene variants in genomically stable tumours. Aanchal Agarwalla is presenting risk of specific types of ovarian cancer after borderline ovarian tumours in Denmark, a nationwide study. And Dr. Nithya Roopa Prem is presenting Follicle cysts of the ovary, a report of 30 cases of a common benign lesion, emphasising its unusual clinical and pathological aspects. So next I'll introduce our three speakers. Rebekah Divakaran is a final year pathology trainee at both Peter MacCallum Cancer Centre and the Royal Women's and Royal Children's Hospitals in Melbourne, Australia. Dr. Aanchal Agarwalla is a third year pathology trainee at Kasturba Medical College in Manipal, India, and her colleague, Dr. Nithya Roopa Prem, is a second year pathology trainee at the same institution. And also at this point, a special thanks to Professor Mary Matthew, who's the Director and Head of the Department of Pathology at Kasturba Medical College, who's assisted greatly in the lead up to today. So with that, I'll now hand over to Rebekah, who will present the first paper. Thank you, Rebekah.
So thanks to Karen and Natalie for the opportunity of presenting today. My topic is quite molecular heavy and it requires a lot of molecular assumed knowledge. Some of those concepts I'll be able to explain a little bit in depth, but there are some aspects of the paper in relation to the molecular that I won't be able to cover completely in full. But I've included some references at the end of the talk that you can refer to if you want to look more into that. So just to bring you up to speed with a bit of background knowledge, high-grade and low-grade serous tumours, which encompass both low-grade serous carcinomas and serous borderline tumours, each have different pathogenesis and molecular profiles. High-grade serous carcinomas are thought to be tuber ovarian in origin, and most of them arise from tubal epithelium and are associated with P53 mutations and high copy number variations. In contrast, low-grade serous carcinomas are thought to evolve from epithelial inclusions via a stepwise evolution that may involve serous borderline tumours. And the genetics of serous borderline tumours and low-grade serous carcinomas largely overlap. The most common molecular alterations we see in low-grade serous tumours involve the RAS-MAPK pathway, and of those, the most common are KRAS mutations, but we also see mutations in NRAS, BRAF, HER2, and PIK3CA. Really, the only difference between the two tumour types is that NRAS mutations generally aren't seen in serous borderline tumours, where they are fairly frequent in low-grade serous carcinomas. Less is known about the molecular alterations other than these main driver mutations. It's important for us to distinguish between high-grade serous carcinomas due to their different treatment options. Up to 20% of high-grade serous carcinomas have BRCA1 or 2 mutations, and they are of clinical significance. And these variants predict response to PARP inhibitors. PARP inhibitors are a relatively new class of drugs which act on the homologous recombination DNA repair pathway, and they work by inhibiting PARP enzymes which play a role in DNA repair. By inhibiting the DNA repair in the homologous recombination deficient cancer cells, this results in cancer cell death. Sensitivity to PARP inhibitors is also associated with BRCA1 hypermethylation status, as well as deficiency in the homologous recombination DNA repair pathway. And you'll see in the literature, they refer to this term BRCA-ness, which encompasses both of those molecular alterations. Just a brief overview of how PARP inhibitors actually work. So we have a cancer cell that's obviously dividing and growing all of the time. And during this multiple cell divisions, mistakes in the DNA accumulate. And in order for the cell to repair these DNA mistakes and continue proliferating, it needs to try and fix the DNA. And there's sort of two main pathways that this could happen. One of them is the homologous recombination repair pathway, and that's heavily dependent on BRCA1 and BRCA2. The problem is when you get a mutation in a BRCA1 and BRCA2, it basically cuts out the ability for the cell to use this pathway. And we can exploit that by adding a PARP inhibitor to block the other pathway. So that means that the cancer cells aren't able to continue proliferating, and you'll get cancer cell death. BRCA1 and BRCA2 mutations in low-grade serous carcinoma have been reported in a limited number of studies. The largest of these was Norquist et al., which showed that 4 out of 70, and all of these were classified as pathogenic germline mutations. It was noted by the authors that they used a 3-tier serous grading system for the histological classification, which may call into question whether these were in fact low-grade serous carcinomas or were actually high-grade serous carcinomas. Less is known about the significance of BRCA mutations in low-grade serous tumours, and these were not included in the PARP trials by design. Unlike high-grade serous carcinomas, where PARP inhibitors are a treatment option, effective systemic therapy for low-grade serous tumours are generally lacking. So this is a citation. So the aim of the study was to characterise the molecular profile of 17 low-grade serous tumours, and they did this via massively parallel sequencing. And the parameters that they reported on were tumour mutation burden and copy number alterations, the presence of RAS-MAPK pathway mutations, and the presence of homologous recombination DNA repair pathway mutations, and that included BRCA1 and BRCA2 genes, which were fully sequenced in all tumours. They also commented on microsatellite stability status, and that was done via the sequencing data rather than immunohistochemistry. So just a bit of a recap, this is the RAS-MAPK pathway, which tends to be one of the tumour pathways that we know quite well due to the mutations that are found in various cancers within the body. But the homologous recombination DNA repair pathway is probably less well known. The main aim of the pathway is to repair double-stranded breaks in DNA. And you can see that BRCA1 and BRCA2 are really crucial to this pathway, such that if you get a mutation, it basically eliminates your ability to use this pathway. So in terms of the case selection, there were 13 low-grade serous carcinomas and 4 serous borderline tumours. Of these, 9 were primary and 8 were recurrent tumours, and these were diagnosed between April 2001 and February 2019 in the University of Pennsylvania Health System. And they excluded high-grade serous carcinomas and other ovarian tumours. H&E stains of all cases were reviewed prior to molecular profiling, and the tumour profiling they used tumour tissue from either the primary or the current tumour. 15 of 17 patients were subjected to a 592 gene panel, and 2 out of the 17 were profiled using an older 46 gene panel, and that included 44 genes plus full gene sequencing reactions for BRCA1 and BRCA2 genes. They also reported on copy number alterations and tumour mutation burden, and the MSI status was measured by direct analysis of known microsatellite regions within the 592 gene panel. So in terms of the results, the demographic data showed that age at diagnosis ranged from 17 to 66 years. All of the patients had FIGO stage 3 or recurrent disease at the time of profiling, and all cases histologically showed classic low-grade serous carcinoma or serous borderline tumour. All of the serous borderline tumours showed at least focal micropapillary growth, and at least 2 had microinvasion. The tumour mutation burden in most of the tumours was assessed as low, and the range was 3 to 10 mutations per megabase. So for reference, anything from 10 and above mutations per megabase is considered a high tumour mutation burden. All of the tumours for which microsatellite stability data was available showed stability, and none of the tumours showed mutations in POLE, POLD, or P53. Mutations in both RAS-MAPK pathway and the homologous recombination DNA repair pathway were demonstrated, and of these, KRAS was the most common mutation in the RAS-MAPK pathway, and BRCA2 mutations were the most common alterations in the homologous recombination DNA repair pathway. BRCA1 mutations were not found. All of the BRCA2 mutations were assessed as being variants of unknown clinical significance or benign/likely benign, and at least 2 of these mutations were confirmed to be germline. So this is a table just summarising some of the results. So you can see on the left the different tumours and the common mutations that they found within the tumours. They also reported on the copy number alterations, which for most of the tumours, they didn't have any. There was just a couple that had intermediate levels of copy number alterations. The tumor mutation burden was generally low for most of the tumors. And as you can see, all of the tumors that the data was available were microsatellite stable. So overall, this paints a picture of these tumors being generally genomically stable. This is a waterfall plot, which shows the tumors down the bottom, and each column corresponds to a single tumor. Up the top, you can see the tumor mutation burden, which across the board was relatively low. And to the left, you can see the common mutations that were found. So in the top left-hand box, you see all the mutations that were found in the RAS-MAPK pathway. Of these, KRAS was the most common mutation seen in 5 of the tumors. And down the bottom, you can see all of the genes that were associated with the homologous recombination DNA repair pathway. And of those, BRCA2 was the most common. They've also shown that color-coded the diagram. So they've shown that most of these mutations were missense mutations. This is just summarizing the data in the BRCA2 gene variants that were found. You can see over here, these are the different tumors. They've provided the location of the variant and the variant type, and in brackets, the variant allele frequency, which I'll come back to in a second. They also went to the effort of getting the family history to try and correlate whether these could be germline mutations. They also reported on the AMP tier, which is standard in molecular reporting. And as you can see, 3 of the tumors had was classified as variants of unknown significance, and 2 of them were likely benign or benign. 2 of the patients had confirmed germline testing by testing further normal tissue. This last patient also had germline testing, however, was given a negative result. But the authors note that potentially they did find this benign mutation and it wasn't reported because the AMP tier was benign. And that's just a convention of the way molecular pathology is reported sometimes. This is the response to PARP inhibitors. So there were 2 patients that were given PARP inhibitors. The first was discontinued after 3 months due to nausea and vomiting and succumbed to disease 1 month later. And the second initially had stable disease for 2 months, but then progressed and succumbed to disease after 5 months of PARP. So what did this study find? Well, it confirmed that this clinically aggressive group of low-grade serous tumors have a low mutational burden and are relatively genomically stable. It confirmed the common driver mutations in low-grade serous carcinoma and serous borderline tumor are similar, with the most common mutations in the RAS-MAPK pathway. But it also showed that there are mutations within the homologous recombination DNA repair pathway, including BRCA2 mutations. It also showed that low-grade serous tumors are usually microsatellite stable. They also demonstrated that in contrast to high-grade serous carcinoma, BRCA2 mutations in low-grade serous tumors in this cohort are at most variants of unknown significance or likely benign/benign, and are thus thought not to contribute significantly to tumorigenesis. The authors suggest that if a pathogenic variant of BRCA2 is found in a serous tumor, that the possibility of a high-grade serous carcinoma would need to be excluded, particularly if concomitant p53 mutations were found. Non-pathogenic BRCA2 variants in this cohort may explain why PARP inhibitors are not as effective in low-grade serous tumors compared to high-grade serous carcinomas. However, more studies would be required to confirm this. I think some of the strengths of this study was the comprehensive gene panel that they used and the full sequencing of the BRCA1 and BRCA2 genes in all samples, and also the fact that they correlated family history, which was particularly important with the BRCA2 mutated group. I think some areas for improvement and limitations specific to this study, the obvious one is that small numbers were tested. Overall, the study relied on comprehensive molecular testing, which not all labs have access to and may limit the practicality of utilising this information in everyday reporting. I think further characterising the family histories of the patients with BRCA2 mutation would strengthen the case for germline mutations, and assessing the MSI status on the remaining tumours would strengthen the case for low-grade serous tumours being generally microsatellite stable. I think larger case series are needed to evaluate the incidence and implications of BRCA2 mutations within serous borderline tumours, and to further characterise PARP inhibitors and whether they're an effective treatment in low-grade serous tumours. So I think some of the potential applications from this study is that non-pathogenic BRCA2 variants in this cohort may explain why PARP inhibitors are not as effective in low-grade serous tumours compared to high-grade serous carcinomas. But again, we would need more studies to confirm this. And we may be being asked more to do some BRCA sequencing in these low-grade serous tumours in the future, just based on the fact that they were found in this study and a handful of other studies. And these are my references.
Well done, Beck. That was fantastic. Thank you. You've taken what's really intimidating molecular paper and demystified it and made it understandable for the average histopathologist. So thank you for that. We'll take questions at the end. So we'll now move on to Aanchal's presentation. Aanchal, if you'd like to share your screen.
Yes, ma'am.
Thank you. Wonderful, we can see that. Thank you. Go ahead when you're ready.
Hello, everyone. I would like to thank ISGyP for giving me this opportunity to present this article titled Risk of Specific Type of Ovarian Cancer After Borderline Ovarian Tumors in Denmark, a Nationwide Study by Hannibal et al. Yes, ma'am. So before starting the article, I would like to talk about a little bit about borderline ovarian tumors. So borderline ovarian tumors are called the atypical proliferative tumors, and they're regarded as an immediate precursor of some epithelial ovarian carcinomas, specifically low-grade serous endometrioid, clear cell, and mucinous ovarian cancer. So this table here shows the features, it summarizes the features that a borderline ovarian tumor should have. So any tumor is called as a borderline tumor when it has stratification with glandular or papillary proliferation of more than 10%, with nuclear features showing low-grade atypia and without stromal invasion. Borderline ovarian tumors can implant on peritoneal surfaces, which can be non-invasive or invasive. They're common in younger women, especially below 50 years of age. So why is it important to study about borderline ovarian tumors? Borderline ovarian tumor is a diagnosis by pathologists. Although they do not grow invasively, but they proliferate faster than benign tumors. Prognosis of these tumors is usually good, but women who develop borderline ovarian tumor may be at risk of ovarian cancer. So in this article, the authors aim to compare the incidence of specific types of ovarian cancer in women with serous or mucinous borderline tumor in Denmark, with that in the general female population overall, and also with regard to the time since diagnosis and age at the serous or mucinous borderline diagnosis. So it was a nationwide cohort study with up to 36 years of follow-up. All the women with a serous or mucinous borderline tumor diagnosis registered in the Danish Pathology Data Bank during the years 1978 and 2012 through the online portal were included in the study. So if a woman was recorded with more than one type of borderline diagnosis, the first recorded diagnosis was considered. And also when a woman had a serous and mucinous borderline tumor synchronously, which in our article, they state 8 cases showed both tumors, the final diagnosis was regarded as the serous borderline tumor because they are more aggressive with worse prognosis. Women with other histologic types of borderline tumors, such as endometrioid, clear cell, and other epithelial tumors were excluded, and women with a previous or concomitant cancer diagnosis were also excluded. The study cohort was assigned a unique personal identification number, which was the key identifier, and that was used to obtain information like migration, death, ovarian cancer occurrence by linking them to the health registries in Denmark and the Danish cancer registries, and these were all computerized. They were then followed from the date of the first diagnosis until the date of death, emigration, or December 31, 2014, whichever appeared first. statistical analysis was done by calculating the standardized incidence ratio, which was a ratio of observed number of ovarian cases upon the expected number of ovarian cases. And this indicated it was a measure of relative risk for ovarian cancer. Overall, the SIRs were calculated for all women with a serous or mucinous borderline tumor for the following type of ovarian cancer, that is serous, endometrioid, clear cell, mucinous, and other epithelial, non-epithelial, and unspecified tumors. All analyses were also stratified according to the time since diagnosis and according to age at the diagnosis. All statistical analyses were carried out using SASTAT software version 9.3. So the results were as follows. The number of women in the study cohort were 4,281. Women with serous borderline tumor diagnosis comprised 48% of the total number, which is 2,058 cases with a median age of 52 years. Women with mucinous borderline tumor comprised 52% of the total cases, which was 2,223 cases with a median age of 49 years. So in this table, you can see that the standardized incidence ratio, which is the relative risk of a specific tumor following the borderline tumor, be it serous or mucinous, was calculated. And it clearly shows that there was a 5.3 times more increase in relative risk of developing serous cancer following a serous borderline tumor when compared to a normal female population. The second most common tumor type was the adenocarcinoma NOS, which was grouped under other epithelial lesions, which comprised 2.1 times more risk of developing following serous borderline tumors. Similarly, following mucinous borderline tumor, it was expected that 0.9 times there was more risk of developing mucinous ovarian carcinoma than expected in general population, followed by other epithelial tumors. Relative risk was highest within the first year of the follow-up, and it decreased with increasing years of follow-up, but it was still significantly elevated 10 years or more after the serous borderline diagnosis. Relative risk of serous ovarian carcinoma in women with a serous borderline tumor was higher in women below the age of 50 years at the time of diagnosis. Similarly, the relative risk was highly elevated within the first years, and it was significantly high 1 to 4 years after diagnosis, whereas no cancer cases were observed 10 years or more after the mucinous borderline tumor diagnosis. So this table, you can see almost no case was diagnosed after a latent period of more than 10 years. There was the increased SIR of mucinous cancer did not vary significantly with age of borderline tumor. So be it below the age of 50 or above the age of 50, the number of observed cases were almost the same. Finally, in relation to other epithelial ovarian carcinoma, which includes adenocarcinoma NOS commonest, significantly more observed than expected cases were seen 1 year or more after the diagnosis. There is no major difference with regard to age at the diagnosis was seen. The authors also made a sub-cohort which included expert pathologists reviewed confirmed serous borderline cases during 1978 to 2002. It included 865 women with a median age of 49 years, and then they were followed up for 11,371 women years in total. This subcohort was basically made to compare the findings with the total cohort. And it was observed that the risk pattern related to time since age at diagnosis and specific type of tumor among these with a confirmed serous borderline tumor was like that observed in the total cohort. So this table also summarizes the same, that it showed that 8.7 times increased relative risk of developing serous ovarian cancer following a serous borderline tumor, which was much higher than that in expected general population. So coming to the discussion of this paper states that there was approximately 9 times more risk of developing serous ovarian cancer in women with a serous borderline tumor than expected in the general female population. Whereas there was no increase in rate of mucinous ovarian cancer following serous borderline diagnosis. There was approximately 18 times more risk of developing mucinous ovarian cancer in women with a mucinous borderline tumor than that expected in the general female population, with virtually no cases of serous ovarian cancer following a mucinous borderline tumor diagnosis. Serous or mucinous borderline tumor diagnosis, respectively, was not noticeably associated with other specific types of ovarian cancer. The study confirmed that serous borderline tumor is an immediate precursor of serous carcinoma, whereas mucinous borderline ovarian tumor is a precursor of mucinous carcinoma. It was also seen that a large proportion of subsequent serous or mucinous ovarian cancer occurred in the first years of follow-up after the diagnosis of borderline tumor, reflecting that the women already had a concomitant ovarian cancer at the time of serous or mucinous borderline diagnosis rather than tumor progression. Results also showed that there were many cases occurring many years after the serous borderline tumor, which most likely points to tumor prognosis. The relative risk of cancer is most strongly seen in women who were younger at the time of diagnosis, which can be due to extensive surgical treatment among the elder women. In contrast, no major difference with regard to age was seen in women who developed mucinous ovarian cancer following mucinous borderline ovarian tumor diagnosis. Thus, age at diagnosis may have an impact on women diagnosed with serous borderline tumor, whereas this does not seem to be the case for women diagnosed with mucinous borderline tumor. Both groups also had an elevated relative risk for the group of other epithelial ovarian cancers, which comprised mainly of adenocarcinomas, NOS. So this study had a lot of strengths. So it comprised of a large number of study subjects with sufficient statistical evidence. It was the first study to investigate the impact of time since and the age at diagnosis of borderline tumor, and furthermore to calculate rates of specific type of ovarian cancer. The authors had no loss to follow-up, and there was no recall bias as information both about the exposure and the outcome was register-based. According to me, the few areas of improvement could be that the study precluded a distinction between low-grade and high-grade serous carcinoma. However, based on findings from previous study, the authors believe that the number of high-grade serous ovarian carcinomas following serous borderline diagnosis is limited. They did not specify whether a serous borderline tumor was micropapillary variant or not. The authors were unable to adjust for other potential confounders that could have affected the association between borderline tumors and subsequent ovarian cancer. For example, findings and procedures related to the treatment of the borderline tumors. And there was no information about the stage of diagnosis or the specific types of implants of serous borderline tumor, because the latter can also be is also regarded as a low-grade serous borderline tumor according to the latest WHO. So in my opinion, the findings can be very, very well implemented in regular practice. The paper alerts us to the potential increased risk of subsequent cancer and justifies the ongoing follow-up of these patients up to and beyond 10 years. Hence, the patients, especially below the age of 50 years, in case of serous borderline tumors, must be diligently and frequently followed up for a minimum period of 1 year, and thereby up to 10 years in comparatively longer intervals for the development of subsequent epithelial ovarian cancer of respective type. Thank you.
Well done, Aanchal. That was amazing. Thank you. Very thorough presentation. All right, so we'll now move on to our third presentation, Dr. Nithya, Roopa, Prem. Nithya, if you'd like to share your screen. That's great. We can see that. Thank you. The podium's now yours, Nithya. Thank you. Nithya, have you unmuted yourself?
Yeah, I'm Nithya Roopa Prem. Yeah, I'm Nithya Roopa Prem.
Thank
Second
you.
year
Go ahead.
postgraduate, Kasturba Medical College, Karnataka, India. So I'm here to present an interesting paper on follicle cyst of ovary, a report of 30 cases of common benign lesion, emphasizing its unusual clinical and pathological aspect, by Jacqueline Watkins and Robert Young, and published in International Journal of Gynecological Pathology in July 2021. So introduction, follicle cyst, it represents non-neoplastic lesion of ovary that occurs at any age, including in neonates and children. So as you all know, physiologically, ovarian follicle matures during proliferative phase of menstrual cycle, where the mature oocyte gets released due to LH surge at mid-cycle and the follicle transformed into corpus luteum. If no fertilization takes place, the corpus luteum atrophies and form corpus albicans. Now, follicle cyst in children, it occurs due to in utero stimulation of maternal hormones due to estrogen production or due to estrogen production in significant amount, resulting in isosexual precocity in association with McCune-Albright syndrome or hypothyroidism. In postmenopausal patients, the follicle cyst is very rare. It's associated with signs of hyperestrogenism, such as postmenopausal bleeding. In reproductive era, the follicle cyst is seen in association with pregnancy, like large solitary luteinized follicle cyst of pregnancy or hyperreactio luteinalis. Other rare examples may be due to complication like pituitary adenoma, hypothyroidism, iatrogenic ovarian stimulation, or as a component of so-called ovarian remnant syndrome. Macroscopically, follicle cyst is usually solitary, 3 to 8 centimeter. The cyst wall is thin with smooth inner lining and contains clear to hemorrhagic fluid. So it has generally been thought that, except in pregnancy, the mere size of lesion is very crucial in distinguishing between the follicle cyst and adult granulosa cell tumor, as we rarely consider follicle cyst more than 8 centimeter. So the aim of the journal is to understand the unusual aspect of follicle cyst, along with differentiating with other entities like corpus luteal cyst, and the most importantly, the granulosa cell tumors. Materials and methods. 30 cases were obtained from consultation files of late Dr. Robert Shuley. From 1 to 17 H&E slides were available for review. Clinical and gross findings were obtained from consultation correspondence. So the histopathological features evaluated included, first, for the number of cell layers, degree of luteinization, and cytological features. So results, the average age was 16.9 years, ranging from 3 days to 47-year-old. So out of which 7 patients were less than 4 months who was presented with abdominal mass, some of which was diagnosed antenatally as ovarian cyst. 9 patients who in the age group of 1 to 7 years presented with precocious puberty. 8 patients presented with pelvic pain or acute abdomen, and the remaining cases, 4 patients presented with pelvic mass during evaluation of pelvic inflammatory disease, 1 case secondary to clomiphene administration. 2 patients, of which 1 patient had history of incomplete residual pituitary adenoma at the time of diagnosis, and other one with FSH secreting pituitary adenoma, which was diagnosed 3 years later after diagnosis of bilateral follicle cyst. Gross features, the average diameter of the cyst is 5.9 centimeter, out of which 7 were more than 8 centimeter, and 10 cases showed smooth external surface, with 12 having small secondary cyst in the wall of dominant cyst. The microscopic features, 11 cases showed multiple cysts, but all had a dominant cyst with satellite cystic follicles. 3 showed eosinophilic secretion, 8 cases showed hemorrhagic contents, and 2 cases showed calcification in the wall of the cyst, and both were neonatal cases. Also, 2 cases also showed hemosiderin-laden macrophages. So this is the diagram showing follicle cyst of 10 centimeter with smooth lining and small satellite cyst. This is the microscopic picture showing small satellite cyst seen adjacent to the follicle cyst. Now, depending on the granulosa cell lining, the average number of cell layers in 28 cases were 6, thickest with ranging from thickest foci 3 to 10 cells. 2 cases showed entirely denuded granulosa layer, 1 case a neonate and a child with precocious puberty. Now, this granulosa cell displays round nuclei, uniformly lacked nuclear group, and occasional small nucleoli. Apoptosis was frequent in granulosa cell layer in 18 cases. This mitosis was absent in 14 cases, but ranged from 1 to 36 per 10 high power field, the remaining 14 cases with intact granulosa cell layer. 5 cases showed mild nuclear atypia. Mitotic activity in pica interna was absent in 22 cases, ranging from 1 to 18 per 10 high power field in the remaining 8 cases. So here in this diagram, you can see the mitotic figures in the granulosa cell layer, and 5 cases showed mild nuclear atypia in the form of slight nuclear enlargement. Now, based on the luteinization, the cyst was categorized into 6 unluteinized cysts, then 6 granulosa lutein cysts, then 10 theca lutein cysts, and 1 cyst was equally luteinized in both components, and 7 cases showed signs of involution. So this is the figure showing luteinization in the granulosa cell. Of 16 cases showed luteinization in the granulosa cell layer, then 21 cases showed luteinization in theca interna, and 1 case showed luteinization in both the layers. There's the diagram showing involuting follicle cyst with scattered theca cells and eosinophils, suggesting autoimmune oophorytis. So discussion, differentials of follicle cyst include cystic granulosa cell tumor, either adult or juvenile type, but it's very challenging due to overlapping pathological and clinical features. So follicle cyst, in our case, 23% of the cases showed more than 8 centimeters. Mostly it was unilateral, thin wall with smooth external surface. Microscopically lined by outer layer of theca cells with inner layer of granulosa cell lined by uniform nuclei lacking nuclear groove. Whereas the differential of granulosa cell tumor comes if the follicle cyst is more than 8 centimeters or the patient present with isosexual precocity or virilization. Mostly it is unilateral with thicker wall, in some cases present with copious hemorrhage. Now microscopically, it shows thickened granulosa layer with heterogeneous growth pattern like corded, trabecular, microfollicular, etc., along with nuclear groups. And it also shows invagination into the cyst wall. So nuclear groove is very diagnostic trait of adult granulosa cell tumor, but in luteinized granulosa cell tumor, where the nuclear groove is indistinct, therefore extensive sampling is required. Atypia is very rare in granulosa cell tumor, but if present, it might be bizarre. Spotty bizarre nuclear atypia is a characteristic of giant follicle cysts that are pregnancy related. Now, the other differential is juvenile granulosa cell tumor, where the cells have pale to vacuolated cytoplasm. Nuclear groups are not prominent. The characteristic pattern is the follicular differentiation in the background of solid growth. The other differential is the benign entity like corpus luteum cyst, which shows an inner granulosa cell layer and outer theca layer, along with marked luteinization, that is abundant eosinophilic cytoplasm, polygonal shaped cells, along with inner fibrous lining secondary to organizing hemorrhage. Then denuded endometriotic cyst. It also, the diagnosis depends on endometriosis elsewhere, along with hemosiderin-laden macrophages and pseudoxanthoma cells. And also simple cyst, which occurs in the late stages of involution. So this is the diagram showing corpus luteum cyst, which shows polygonal cells with abundant to eosinophilic cytoplasm. Here also, you can see the inner fibrous lining secondary to organizing hemorrhage. So follicle cyst, it can arise from abnormal ovarian stimulation, which broadly it is categorized into 3 etiological categories. First one is aberrant pituitary ovarian axis function due to excess FSH, iatrogenic, example ovulation induction, and idiopathic. Depending on particular etiology of cyst based on the luteinization pattern, unluteinized cyst would secrete estradiol in clinical scenario like ovulation induction, pituitary abnormalities, and idiopathic. Then granulosa lutein cyst would secrete progesterone, result from failure of follicle rupture at the time of ovulation. It's known as luteinized unruptured follicle syndrome. Then theca lutein cyst would secrete androstenedione. It developed with prolonged LH exposure, for example, PCOS, or with exposure to beta HCG in case of pregnancy. So this is the table showing the follicle cyst in non-pregnant cases. Here you can see the 7 cases neonatal follicle cyst. The etiology is either due to estrogen or placental beta HCG. Now, 9 cases included the prepubertal group, that is 1 to 9 years of 9 years, with clinical setting of isosexual pseudoprecocity, McCune-Albright syndrome, and primary hypothyroidism. These 3 entities are the cause of pseudopuberty. They are gonadotropin independent, whereas central precocious puberty, they are gonadotropin dependent. It is due to true activation of hypothalamic pituitary gonadal axis, and it usually have bilateral involvement. So as you know, follicle cyst it is very common lesion which rarely secrete hormones to disturb either the menstrual cycle or cause virilization. So generally cyst regress its own. If it is persisting, it raises the suspicion for neoplasia. So the important part is the unusual clinical pathological setting of follicle cyst can occur when the patients, in this case, patient with gonadotropic pituitary adenoma, they develop ovarian hyperstimulation syndrome, resulting in enlarged multicystic ovaries. One of the patient had pituitary adenoma, was found to have bilateral large luteinized cyst, and it was diagnosed as cystic granulosa cell tumor. But 3 years later was found to have FSH secreting adenoma, which led to review of original ovarian pathology. The other one is ovarian in reproductive years, for like ovarian remnant syndrome, that is residual in situ ovarian tissue after presumed bilateral oophorectomy. Then multiple follicle cysts with inflammation such as lymphocytic may suggest autoimmune oophoreitis. One of the cases showed eosinophils in the inflammatory infiltrate, was known as eosinophilic perifolliculitis. Now, as you know, postmenopausal period follicle cyst is very rare. It's associated with signs of hyperestrogenism, such as postmenopausal bleeding, which this clinical presentation, it creates a concern for clinician to suspect adult granulosa cell tumor. Then in pregnancy, it can be either hyperreaction luteinalis and large solitary luteinized follicle cyst of pregnancy and purpurium. So the strength of the study is the author showed unusual clinical setting in which follicle cysts may arise and how to differentiate with other benign entity like corpus luteum cyst, etc. It also helps us to distinguish between follicle cyst and granulosa cell tumor, which is very challenging. The areas of improvement, large size of sample size could be included. And in this study, only consultation cases were included, which is enriched for unusual features. So it does not reflect our day-to-day practice. Application. It is very important for the pathologist to know about the clinical presentation to avoid overdiagnosis as granulosa cell tumors. And follicle cysts can be large size up to 18.5 centimeter. So size criteria is not a reliable criteria. It's just a clue. And follicle cysts have delicate thin wall compared to granulosa cell tumor. The cellular features including absence of nuclear groove, round nuclei, without significant atypia, moderate amount of cytoplasm, all are reliable features which aid in diagnosis. Thank you.
Well done, Nithya. Thank you. That was fantastic.
Thanks.
If everyone would like to unmute themselves and share their screens again. I'm really pleased to say we have a question. This is my first question. Thank you, Carlos. Carlos has asked a question of Aanchal, if Aanchal is there. So the question, Aanchal, is, in the Hannibal et al. Study, can the cancer outcome be related to whether the borderline tumour was resected completely, i.e. oophorectomy, versus partially, cystectomy? Also, does the paper mention how extensively were the tumours sampled? And finally, does the study document the initial stage of the borderline tumour at the time of first diagnosis?
Yes, so it was a major drawback of this study that the authors did not specify if the ovarian tumors, the borderline tumors, were extensively sampled or not. What was the treatment given to the patient at the time of diagnosis? Also, what stage or what kind of implants did the patient presented with? These were the areas of improvement which I thought they should have included, but they do not mention any such point.
Yeah, I agree, Aanchal. It was a little frustrating, wasn't it, that we were limited in our depth of understanding of how extensively these patients were operated on, whether or not they had invasive implants at time of diagnosis, whether or not they were a micropapillary versus a regular serous borderline ovarian tumour, and also not knowing until we got to the discussion while reading the paper whether or not the serous carcinoma that the tumours progressed to was low grade or high grade. So there are a couple of problematic issues, weren't there? Another question that popped into my mind is they collected tumours as far back as 1978, and I wonder how they were being diagnosed back then, and if the same diagnostic criteria were in use as are in more recent decades.
No, I think serous borderline tumors are one of the tumors that have undergone the most change in nomenclature. So I'm pretty positive that they wouldn't have been. And to address Carlos's question about the surgery, if you look in the paper, they don't actually note that anyone got a cystectomy, which is one of his questions. They all either got unilateral salpingo oophorectomy or BSOs. So I don't, and it doesn't say that they specifically excluded those patients. So maybe it's possible they just don't do those surgeries there. I don't know. I mean, in the States, certainly we see cystectomies in young patients, you know, for fertility sparing, obviously.
Yes, ma'am. One of the points what the authors put here is that they've seen most number of cases of ovarian cancer following borderline tumors in younger patients. So this can be included the elder patient who are getting a bilateral salpingo oophorectomy rather than as compared to the younger women.
Right, that's a good point. Yeah, good point. Oh, we have something in the chat as well.
And in light of what this paper showed, do you think we should be operating more aggressively in younger women? Because the rate of serous carcinoma was higher in women under 50 after a diagnosis of borderline ovarian tumor.
Yeah, I mean, that's a hard sell, isn't it?
It's a really hard question.
For fertility and the, you know, like Aanchal said, the lack of therapies for these patients, we don't really, and I think, Beck, you also touched on that, you know, that the low-grade tumors compared to the high-grade tumors, we don't really have many things to target, and the things we have, they don't really work that well. But there are features that we know predict worse behavior. So I think, you know, someone raised the question of sampling. That's always my first question when looking at a serous tumor. How well is it sampled? Sometimes that's the only thing you have.
Another question that I had, and Carlos has just added, yes, it's a great paper, but so many questions from the pathology perspective. Another question I had that I felt a little unresolved on was exploring why their rate of a cancer diagnosis was so high in the first 12 months after the initial diagnosis of a borderline tumor. Does that mean that they went back, took the patient back to theatre in that first 12 months and did a completion oophorectomy, or and then found that it was in fact a malignancy all along, and so it was a concomitant diagnosis, which is what you stated, Aanchal. And so does that weaken the argument that borderline ovarian tumor has a high rate of progression to malignancy? But in the discussion, they do address that by saying that there were still more observed than expected cases after that 12-month period. Right. That maybe the SIR, the standardized incidence ratio, isn't quite as high as they reported.
Yeah, that's a good point. Yeah, because that 12-month. I mean, traditionally, when you think of these tumors, it takes a little bit longer than that. So that might be some noise. Yeah.
And then the other question is, given that even up to 10 years, there was still a risk of tumor progression to malignancy. I wonder how long these patients are followed up, what the standard of care is for borderline neoplasia. Do you have any feel for that?
So they said that they've made a sub-cohort up to 2002. This study included all the cases up to 2012, but they made a sub-cohort with confirmed cases of serous borderline tumors up to 2002. Probably that is where they made a comparison between what they found out in the total cohort as compared to the sub-cohort study.
Yep.
Because that had more number of follow-up years.
But in routine practice, what is the norm after a serous borderline diagnosis or a mucinous borderline diagnosis? Are these patients kept in follow-up, ongoing follow-up for a protracted period?
Ma'am, if the patient is younger age group, according to me, I feel they should be very frequently followed up for a period of 1 year. And following that, they can be routinely followed up for a longer period of intervals, because this paper shows that whether be concomitant ovarian tumor or tumor progression, it is important to pick up a diagnosis of low-grade or high-grade serous ovarian cancer. So in my opinion, I think they should be followed up more diligently at frequent intervals before up to 1 year of age, at least.
Yep. Yeah, I guess I'm curious if that really does happen.
No, I know it's hard because how would you follow them, right? I don't actually know the answer to this question because it seems like it would be pretty invasive, especially in young patients, to do a bunch of imaging studies and expose them to radiation. And so a lot of times in these patients, they do pelvic exams or something, but at what point is that really sensitive enough to detect what you're looking for? So it's a really good question.
That's right. A lot of unanswered and quite provocative questions from this paper.
Yes.
We've got another question from Carlos. Thank you, Carlos. In the Watkins paper, so this is for you, Nithya, did any of the follicular cysts have architecture other than flat, so a stratified lining, papillary tufts, or bridging?
No, like more than 10 cases showed smooth. Most of the cases showed smooth lining. There was no papillary bridging or architecture, anything.
I knew that answer right off the top of her.
And I think that was listed as one of the reassuring features when we're deliberating with a larger follicular cyst about the possibility of a granulosa cell tumor. And I thought that was the real takeaway from this paper and why it was so useful. Because
there's a common assumption that follicle cyst will be generally less than 8 centimeter. But in our case, we saw that like 7 cases showed more than 8 centimeter size follicle cyst.
Yeah, absolutely. So when we get one of these massive follicle cysts, do we need to block it like we would, block per centimeter? Do you think, knowing that granulosa cell tumors are more likely to be the larger lesions, I guess we really need to be very cautious when we're examining these. And that was one of the points. We need to sample widely and look hard for these clues that help us make a diagnosis of a cystic granulosa cell tumor.
Yes.
I mean, it's not very common that you see a follicle cyst that's more than a couple of blocks, but if it is bigger, do you think we need to go back and put more tissue on?
Yes, we have to actually do extensive sampling to see whether like nuclear groove is present. In case of luteinized granulosa cell tumor, the nuclear groove is not very distinct. So we have to do extensive sampling.
Yeah. And Carlos actually put another question in. Did you see? He said he's seen cystic adult granulosa cell tumors that have fibrovascular cores, which would not be expected in a cyst. So, and any self-respecting pathologist will say yes when someone asks you, do you want more?
Absolutely.
The answer to that question is always yes. It gives you more time to think, So, and
block per centimeter. Rules for life.
Yes, the answer to that question is always yes. If the surgeon asks you, do you want more tissue? Yes. I mean, as long as the patient's okay and everything's okay, you always want more opportunities to see morphology. So yeah.
The other thing I thought was fascinating from your paper, Nithya, was how common these lesions are in children and neonates. I had no idea, which just reflects the fact that pediatric pathology is a subspecialty and we don't get exposure to it. But goodness me, so many neonatal and childhood presentations. Yeah.
Yes. Yeah.
So it's quite fascinating. And obviously reflects the fact that these were consultation cases. And I think I would panic if I saw a big cystic lesion in a young child as well. I'd be sending it off to an expert. Beck, we haven't talked much about your paper, which was a really challenging one.
Yeah.
I think it scared everyone off because molecular pathology is hard to the average histopathologist, as I said earlier. And I have such a binary, non-nuanced perception of molecular findings. So really interesting for me to know that a BRCA2 mutation doesn't mean that you've got something that is going to be treatable with PARP inhibitors and that it's going to be of clinical significance. So that for me was one of the learning points, is to recognise that you need to drill down and understand the nature of the mutation.
Yeah.
What was your main takeaway from this paper?
Yeah, I think I hadn't really heard of the homologous recombination DNA repair pathway being like a big factor in low-grade serous tumors before reading this paper. Like I kind of always just thought, the MAPK pathway was the one that we need to target, and it's the one that they're trying to find treatments for. So I think the most up-to-date treatments they're looking at now are MEK inhibitors for that, to target that pathway.
Yeah.
So yeah, I think the takeaway for me was just the fact that the homologous recombination sort of DNA repair pathway is a factor. So it'll be interesting in the future if they do some more molecular studies in the low-grade tumours, whether they can find something targetable.
Yeah, it feels a little bit like these are the forgotten patients. There's been so much emphasis on the high-grade tumours and the exciting developments of understanding the precursor lesions in the fallopian tube and hereditary familial cancer syndrome and treatment modalities. And I felt a bit depressed at the end of the paper for the low-grade serous cancer patients that even if there was a BRCA mutation, they weren't necessarily amenable to PARP inhibitor therapy. And yeah, I agree. I feel like there needs to be a continued effort to sequence these tumours and see whether there is anything else that might be on offer. And obviously the MEK inhibitor trials are ongoing. So yeah, so for me that was the main takeaway, I guess. A sense of there's still a lot more work to do for these hard to treat tumours, chemo resistant and limited therapeutic options. We've hit the end of the hour. Do you think it's time to wrap up?
I do. I want to thank all three of the presenters. You all did such a lovely job. Really good job.
Yeah, I'm super impressed with all of you. Well done.
Thank you.
Nithya and Aanchal, second and third year. So brave of you to come on and present. Well done. And Rebekah, yours was a really sophisticated presentation. That was great. Thank you. And thank you to the audience as well. We've got some nice comments. Congratulations to all for such amazing presentations. So well done, everybody. And thank you, everyone, for joining. And see you all next time.
Yeah,
thank you, Natalie.
Your segue on the way out. Okay.
Yes,
bye, everyone.
indeed.
Thank you.
Thank you.
Bye.
Thank you. Bye.
Bye.